Okay, it looks like we've got a good group here, so I'm going to get started with some introductions. I'm Theresa Williamson. I'm a neurosurgeon at Brown University Health and also a part-time lecturer here at Harvard Medical School and at the Center for Bioethics, where I chair the Harvard Surgical Ethics Working Group that is supporting this seminar today. And first things first, I want to thank the Harvard Medical School Center for Bioethics for their support, particularly Lisa Bastille and Becca Brendel and the entire team at the Center for Bioethics, who has really helped us to put this together and make an excellent program for today. And then also thank you to Nichelle, who is our clinical research coordinator at the Neurotech Justice Accelerator at MGB, who has also been diligently supporting the behind the scenes for this panel. So this panel is all about the ethical implications of artificial intelligence in surgical training and practice. So what we're hoping to do today is look at the ethical implications of integrating AI into surgical training and clinical practice. We're very fortunate to have with us here some real experts in the fields of AI and clinical medicine and AI in surgery. I'll talk about the presenters in the order in which they will be discussing. So first up, we have Dr. Krystle Tuaño, who is a board-certified general surgeon and plastic and reconstructive surgeon, who has obviously a lot of clinical expertise in hand and upper extremity surgery and microsurgery. And from the research standpoint, has worked on surgical training in AI as well as research and AI at MGH. We are also going to hear from Dr. Danielle Bitterman, who's a radiation oncologist at MGB and also a physician scientist who chairs and is the clinical lead for the Center for Digital Health at MGB. Finally, we'll hear from Dr. Rohaid Ali, who's a spine fellow at Mass General Brigham, and who has a lot of expertise in the practical applications of AI in clinical surgery. All of the panelists together, I can't list the number of, New England Journal and JAMA and Digital and New England Journal AI papers that they've all published. But I think it's really timely. There was actually just an article in New England Journal of Medicine AI thinking about the implications and really how hospital systems, practices, et cetera, need to utilize AI to continue to support clinical care. So I'll ask Dr. Dr. Bitterman to go first and to talk a little bit about sort of some of the clinical and regulatory aspects of AI.
Hi everyone. I'm Danielle Bitterman. I'm not a surgeon. I'm a radiation oncologist at Mass General Brigham Cancer Institute. And I lead a lab that's focused on the use of AI and in specific natural language processing, which is AI applied to human language, primarily for oncology applications. My lab has three kind of main pillars of our research. The first is I do a lot of work in using natural language processing methods to uh, develop computational phenotypes from the electronic health records. And the goal of that work is to advance real-world evidence generation and clinical trial processes in oncology. The second pillar of my lab's research is translational AI for oncology. So, as a physician scientist, I'm really committed not just to developing new technical methods, but also thinking through how we can bridge this so-called valley of death between AI, kind of the most modern AI methods development and successfully translating that into new technologies that are safely, sustainably, and durably implemented in clinical settings. And so I do a lot of work in developing evidence for AI methods as they emerge, and that includes clinical trials of new AI technologies in the kind of general healthcare setting, as well as in radiotherapy planning. And finally, and very related to translational considerations, my lab works to advance the science of evaluating large language models and other emerging AI technologies. So my academic training in the AI space is really centered in natural language processing. I did a postdoctoral fellowship in NLP, and the kind of challenges of evaluating text is really central to that field. And those challenges have now kind of made it into clinical questions with the emergence and adoption of large language models, which are the types of AI models that underlie the AI chatbots that we're using kind of in our day-to-day lives, as well as starting to be integrated in clinical practice, such as ChatGPT and Gemini and Claude, et cetera. But we currently don't have validated approaches to monitor and oversee these methods once they're rolled out in clinic at a large scale setting. And so we are working to build clinically aligned evaluation and oversight methods to support the safe translation of these methods into clinical practice. Next slide, please. And as it pertains to the topic of this panel, I want to talk a little bit about, in a bit more kind of a deeper dive into this question of evaluating large language model and generative AI output and why that presents both safety challenges and why addressing this is really critical to trust and ethical use of these models. So the way we standardly evaluate large language models that have generated text output is shown here on the left, which is via benchmark data sets. So multi-choice question answering exams, including the US medical licensing exams. These are really helpful in some ways because they have clear gold standards. You can automate their evaluation because you can just present an accuracy score, and they are fairly standardized. At the same time, they're narrow and they tend to be fairly scoped. What is a big unanswered question is whether the kind of automated evaluation of these benchmark data sets translates into performance for the type of real world applications that we want to use these models for in real clinical settings. So we generally don't need to use these models to answer a multi-choice question and answer exam. We want to use them to help answer questions about about clinical entities, to help us with documentation, and to help us uh, generate new documents to support the kind of educational and informational needs of our patients. The challenge with these applications is that we don't have gold standard data sets to compare model output against. We don't have any way to reliably automate these evaluation of these types of outputs. There are no shared metrics for safety and trust. These tests are broad and non-standard, and you quickly run into safety critical edge cases in medicine where one error, though rare, is likely to occur when these models are rolled out across large populations and can lead to a very serious medical event. So there's a lot of work needed and currently emerging to advance the automated evaluation of these types of model outputs, so that we can move towards a more trustworthy application of these systems in clinical practice. So that's a kind of little bite-sized view of kind of how my lab is addressing and attempting to play one small role in advancing the safe and ethical use of AI today in clinical practice.
Thank you so much, Dr. Bitterman. I know we all have a lot of questions. We're going to try to hold the Q&A, and some even put questions beforehand. So feel free to put questions into the Q&A. We'll be monitoring and hanging on to those questions for our discussion following the introduction to these amazing talks in AI. So thank you. Next up is Dr. Rohaid Ali. Go ahead.
Hi, thank you for that. And as Dr. Williamson mentioned, I'm currently a fellow at Mass General Brigham's Department of Neurosurgery, and this fall I'll be joining the University of Chicago. We can go to the next slide. So I just want to share two quick examples of practical applications of AI in surgical practice. And so one of these has to do with consent forms, surgical consent forms. As we all know, surgical consent is kind of a foundational pillar in modern medical ethics, and the consent form is a key aspect of that. However, these consent forms, on average, are written at a college reading level, that of a college freshman or college sophomore level, despite the fact 50% of Americans don't read above an eighth grade reading level. And so what we did at scale, I was at Brown prior to coming to Harvard Fellowship, is utilizing ChatGPT, we simplified our universal surgical consent form from a college reading level down to a sixth grade reading level. And we actually implemented this in real life. And now it's a surgical consent form utilized in the consent process for over 40,000 procedures per year. I'm proud to see that this has now spread to other institutions as well who have adopted it. Mass General Brigham, for example, has adopted it, and others across the country have adopted it as well. But at the time in 2023, this was considered a big risk. Like, wow, we're going to introduce AI in the clinical space. But no, this is actually a very strong use case, right, of ChatGPT. Its ability to change concepts and words and simplify them. It's a very, it really leverages its strength, and you have humans reviewing it prior to being deployed to patients. The other case example I just want to leave you with, think about, so AI voice cloning technology, oftentimes viewed in a very negative context and for good reason, can be used in, for like nefarious means, for crimes, etc. Well, what about a patient who has dysarthria, difficulty speaking after surgery to remove a brain tumor? In this case, it was a young woman who had lost her ability to speak and was undergoing intensive speech therapy after she had hemangioblastoma removed from her brainstem. And she had some audio that she recorded just prior to that surgery. Using just 15 seconds of that recorded audio, we were able to develop a iPhone app for her where she could just text into the iPhone app, and that app would then produce her voice as it had sounded from that 15 seconds of recorded audio. And she was able to communicate, go order something in a drive-through or communicate with her family or ask her professor a question in class. And while she was recovering, the use of her voice. And so these are just two examples of the utilization of AI in a practical sense in the surgical environment. They get at some key ethical questions and bring up some tensions, but I think it's worth navigating those because ultimately, our goal is just to empower our patients to live the best life they can. And I hope these two methods are ways that we can come closer to achieving that.
Thank you so much, Dr. Ali. Dr. Tuaño, I'll ask you to pull up your slides and look forward to hearing your discussion. We're trying to kind of go all the way from clinical safety to practical applications to now thinking about what is this like for trainees. There were a lot of questions submitted around this topic.
All right. Thank you again so much. Good afternoon. I really appreciate the ability to be part of this panel today, and I'm really excited for the discussion later. So a little bit of background about myself. Again, thank you for the kind introduction, Dr. Williamson. I was a general surgeon in a past life and then trained in general surgery in Las Vegas, and then I completed plastic and reconstructive surgery in Denver. And I finished my hand and upper extremity fellowship here at Mass General, where I was lucky enough to stay on staff. One of the things that I am really proud of is our surgical education and sort of the environment that I'm able to work in, that I'm lucky enough to be a part of, and individualized care. And as that relates to AI, one of the interview questions I was asked when I was interviewing here for hand fellowship was how I navigated getting resident teacher of the year in both general surgery and plastic surgery. And my answer was pretty simple for that. It was to individualize. It was to meet someone where they're at rather than meeting me where I'm at. And no two learners are the same, and no two patients are the same. And that principle has followed me from trainee to educator, and it shapes everything about how I practice. It's also, I think, one of the most important themes and frames to sort of think about when you think about this conversation and AI. AI promises personalization at a scale and predictive models tailored to a patient's anatomy, their comorbidities, and their goals. And that's genuinely exciting. But that same technology, if we are not deliberate about it, it can actually flatten individual patients into population averages. And it can embed these types of historical biases that we were mentioning, and it can create some false confidences. So the individualization that I care about still requires the human being in the room, which I think is a very important question when it comes to applying this to surgical education, especially in the context of complex multidisciplinary care for trauma patients and for reconstructive surgery patients. I think you have to ask the right questions, and you have to hold that the complexity is paramount in this, and there's no actual algorithm yet that can manage to hold that in its entirety. So my practice centers on hand and upper extremity surgery, microsurgery, limb salvage, complex reconstruction, and again, in a multidisciplinary setting. And that brings up themes of quality of life, things like length of stay, financial burden, patient-reported outcomes, and how those are measured. And these are always in focus in general when I come and talk to a patient and I think about ethics. Tools that can flag early discharges, for example, when you're thinking about length of stay, especially in these patients that require very long hospitalizations and then potentially rehabilitation after they're discharged. You analyze these candidates and you think about, for example, pain scores that are associated with this, patient-related outcome measures. But these are only really truly valuable when a clinician interprets them and the output of these in the context of the actual person in front of them. So my research brings in another dimension, which is my fun job within my already fun job, because I truly think I have the coolest job in the world. But I get to partner with the World Climbing Association, formerly the International Federation of Sport Climbing, and I am a medical delegate for this. And then we can have great opportunities to potentially apply machine learning to injury surveillance, biomechanics, and athlete health data longitudinally across not only recreational climbers and Olympic athletes, and the Paralympic athletes, but the community at large. And that has taught me something that I carry into all the conversations that I have about AI, which is that the data only tells you as much as the questions that you ask when you actually design this study. And the output has to pass through the minds and the hands of a clinician again before it reaches the patient. So I come to this conversation excited about what AI can do, and I'm committed to the ethical work that makes it worth doing. And you have to ask yourself the question of who benefits and who bears the risk, and who is not in the training data, because it's not really a detour from good science. I think that is what the good science is. So on that vein, I'm looking forward to the discussion, and I wanted to bring up a couple of clinical cases to sort of start the question and answer session. So speaking of individualized care again, I'm going to start with this patient. So case one is this 32-year-old male that was unfortunately caught in an industrial loom accident. And I'm going to give a disclaimer for those that are a bit squeamish. I did try to choose a case that was a bit less gory, but germane to the conversation. So this is his initial presenting photograph when he came in. And, in my practice, I think a picture's worth 1,000 words and then a video is worth 1,000,000. So I'll show you that in just a second. But with shared decision-making, we ultimately decided on a staged reconstruction with a pedicled abdominal flap. And for him, actually the most important things for him were the appearance of the donor site, the location of the donor site, and then ultimately was for him to actually get a prosthetic. But his real priorities with that were to get a prosthetic that were actually matched to his skin tone and color. So this was eventually what his outcome was and what he chose for his reconstructive option. And in working with the amazing team here, we were actually able to get him sponsored, as well as his cousin who came with him to get this prosthetic in a different state. And they were actually able to match his skin color and tone, which you can see in the fourth picture there. And then shifting gears a bit, and the really fun aspect of my practice is I literally have patients from 0 to 100. My last clinic on Thursday had a patient that was 0 years old and another patient that was 98 years old. So this case is preaxial polydactyly. And this is an 18-month-old baby with right preaxial polydactyly. And this is him in the preoperative holding area. I'm just observing him and sort of playing with a surgical marker. And his parents were also able to provide some color and insight into how he uses his thumb, what bothers him, and how he seems to preferentially use it. But something to think about after I sort of show you these things within the operating room, that was this ultimate outcome, is when I think about AI and application and individualizing care, this top patient, even just in general, if you think about rudimentary things as an adult, he can verbalize things like wants and needs, preferences, things that cause him discomfort. And if something just isn't right. And for the baby, I think about all these things, they really can't do that. And in terms of thinking about functionality or future goals and what support there is, they also can't verbalize them for themselves. So decisions that you make have very significant downstream, long-term and permanent effects in general. And in this baby, it's very paramount. So I think about that when I think about ethics and algorithms that can be applied and how you can apply these to patients at large. So with that, I'll end my slideshow and maybe we can start the conversation.
Thank you all so much for those talks and just a great overview of AI in surgery. I will take the bait from Dr. Tuaño and and talk a little bit about the cases that you just brought up. And so I think, my first question would be actually for Dr. Bitterman in terms of we heard about how we can potentially individualize care for a patient like the trauma patient or a patient like the pediatric patient. So I guess my question is, you talked a little bit or you hinted at it around like, how do we measure that we're doing a good job with AI and individualizing care? And so I wonder in your lab how you would set up evaluation of that type of a study.
Sure, and that's such a good question and so important. It's actually something that we're trying to tackle and struggling with right now. Um, because when you get to the kind of questions of tailoring any output or any decisions, based on an individualized patient needs. First, you're unlikely to have an AI model that has each individual's values kind of embedded directly in that model. That's, not feasible. You can't articulate kind of values in that way such that a model could learn it and a priori like be able to identify for this patient this is going to be the right type of content. It's then further complicated by the fact that we traditionally evaluate models based on kind of having humans decide whether they like the outcome or if it's acceptable, whichever metric is appropriate for the setting. And you know that humans are going to disagree. So you have multiple humans do the evaluation of a same outcome, and you kind of compare, do the models, at least disagree similarly to two humans to each other. But for these types of really individualized decision makings, that's not possible because, by definition, humans are not going to agree on a given outcome. So we can create a model that can seemingly, but if you have expert clinicians review the decisions, and you have, one or a small set of patients review the decisions, you can make it can appear as if your model is performing really, really well. But then as soon as you apply it to an individual patient, if their desires are slightly different, the performance will quickly fall apart. We are currently tackling that in the setting of developing chatbots for informed consent, which is part of a PCORI funded award, where we've developed chatbots. We have clinician experts kind of evaluate the quality. We've developed a validated rubric for the clinicians to evaluate against. And we're developing an AI model itself to mimic the human evaluator so we can scale that up. However, when we kind of then bring the output to individual patients, we see performance seemingly start to decline because each patient has slightly different needs. Some people, for example, when we kind of assess readability, find that writing out magnetic resonance imaging versus just showing the abbreviation is more readable, and some people prefer the flipped version. So it's really challenging. I think starting by being aware that there's not a single kind of evaluator that's going to be the solution, and identifying what part of your question is really objective, for which of your metrics is really objective and which are subjective, is super important upfront. Try and push the kind of objective performance as much as possible. And then when you get to the subjective markers, that really needs to be evaluated in real world clinical settings. I don't think it's something that is really automatable.
And just to follow up on that, because I do love that. That's not actually a way that I've heard it framed before of like it actually kind of gives me like a sense of relief. Like, okay, measure the objective things that AI is doing in surgery objectively, and then the subjective things, identify them because they're still important. And then I think what you're saying is have a human or a clinical human or patient or provider evaluator of that rather than trying to evaluate something subjective.
Right.
Interesting. Really cool. Dr. Ali, I saw you kind of nodding your head, and I know you've done some work in consent. Any thoughts here to add to this question?
Oh yeah, I mean that's a brilliant point that she's making. I mean, it really just individualizing it to the patient specific level, I think is just key in doing all this and figuring out exactly right those objective metrics. I mean, I think the example she showed on her slide was like a very beautiful illustration of that, right? These clinical scenarios don't present themselves in these multiple choice formats, right? They're very hazy and qualitative, right? And even just the question that you ask is very qualitative. Like, which question do you ask in a clinical environment, and knowing which question to ask, that's key. So I think one of the things that I look at in AI and kind of tracking the progress of these tools over time is I think we all have these like collections, a couple of questions that we ask that we see that we use to evaluate if a model is getting better over time. I remember as a trainee, even just 2 years ago, asking some of these models to walk me through, hey, how do I do the surgery that I'm about to do tomorrow, right? And it's just very entertaining back then asking an LLM to take you through surgery because it'll tell you the most ridiculous thing. You bring the patient in the room, you flip them on their stomach, and then you intubate them. Then you make an incision, place screws, and then you expose the area that you're placing the screws. I mean, it was just everything that was, backwards, right? Whereas now you ask those questions and wow, it's all of a sudden it's very precise. And it's getting to a point where those questions I have that the models are not able to answer are becoming fewer and fewer and fewer. And the question I have is when do I start becoming the thing that inhibits, the model in terms of what's the next best course of action? I think an analogy in our field, Dr. Williamson, you know it well, is navigation assisted, robot assisted spine surgery. Previously, everyone was placing these screws, quote unquote, freehand without any navigation. And now I, as someone who's just 1 year into fellowship, into practice, can place a better screw, a bigger screw at a better angle than any other, freehand surgeon in the world with the use of a robot, right? And so when do we decide we have to get out of the way to allow the tools to, enact the benefit that they can?
I think that's a really good question. And Dr. Tuaño, I think you're going to answer it too. So yeah, because I think this concept, the ethical concept of beneficence, right? In surgery, when we're thinking about like, and I see a question in the chat actually as like, could you make the hand smarter than a human hand? I think getting at the idea of like, how enhanced can we get and how enhanced should we get when we're trying to provide the patient with the absolute best outcome?
Yeah, I think that's a really interesting question to bring up and something that I've thought about a lot, especially as someone that really values education, as all of us do. And as we sort of transition different roles, becoming a mentor to mentees and having been, very green in the operating room to becoming more experienced and now having like all these tools, you wonder, as you were mentioning, are you the one that's the rate limiting factor? And something that I thought was interesting in these sort of AI applications and resident surgical training when it's standardized is the negative activating emotions that occur. Because I can tell you every single time somebody asks me a question and it sort of, so to speak, lights that fire under you and you're like, oh my gosh, and you never remember that, or you never forget that moment because you're like, oh man, somebody asked me that question at this time. I looked it up. I remembered that patient. And then I changed that part of how I do surgery or how I think about things. And it's the proverbial more modern way of saying maybe, did you look it up yourself? Because you're never going to forget it if you looked it up yourself. And I wonder if the ease of getting these things, affects that. And I think the thing to remember is how surgical judgment is formed, and that just takes time and experience. And something that we would often hear is nothing ruins a good outcome like long-term follow-up, and you just need that experience to go through it. So watching somebody like a trainee going through things real time and walking through that uncertainty is irreplaceable. So for me, the ethical risk in applying AI isn't the technicalities of it. Like, in fact, you can make people more technically accurate. And you can maybe get to diagnoses faster. Like it can comb through a chart faster and see medication interactions, or maybe even double checking with things with imaging that are standardized. But I think the risk is more subtle. It's that the trainees actually will become proficient at executing these steps technically excellently. For example, like, the whole adage of people playing video games and then suddenly being good at robotics. But it's that without the development of the capacity to navigate the ambiguity that happens in surgery or the spontaneity of it, and for example, recognizing when to stop or how to indicate a patient for surgery when it's just not right for them, and knowing when a case has like exceeded that plan, and how to sit with a patient and hold their hand and talk them through a complication, or even how to sit and talk yourself through a complication. I think that's where the ethical concerns arise.
I'm so glad you bring that up because it actually gets to a couple of our pre-submitted questions around AI in surgical training. So to shift just a slight bit, one of the things that we think a lot about is, this concept where I was actually having this conversation in the context of my daughter who's in elementary school of, this concept of, is the generation of folks who sat down, read it in a book, and then, learned it through experience, like how and when can learning shift? And so if we are using AI in surgical training, right, like, to help with boards preparation, to help with preparation for a case, is that learning actually different? I think it is in a way, but like, is it different in a way that will matter eventually for patient outcomes? And then someone also asked the question of, what role potentially, kind of like Dr. Bitterman's point of when you get from the objective to the subjective, can like a tutor or a human trainer play in those cases to not stand in the way, again, not say like, don't use an AI tool that could make you better because we want you to learn it the good old fashioned way. But use this tool to make you better. And now my role is X. I think a lot of the surgeons on the call, particularly those that trained before the era of AI, which even I, who, I'm relatively early in my practice, trained before AI was really a thing in training. So, how can we guide sort of our more senior surgeons around this concept? Everyone's hiding from that one. Dr. Ali, you want to go first?
And I know, I think we're just, relatively early in our training. We're differential to senior surgeons, but I think that, I think that everyone is starting to recognize there's a lot of potential here in AI, so-called AI tutors, in the educational process of becoming a surgeon. I mean, one thing that we haven't explicitly called out here that I think is worth noting is that, this term that's been coined in the past few years, a jagged frontier with AI capabilities, right? We, in the surgical field, and a lot of what we do in medicine more broadly, is, blue collar work, right? A lot of what we do is just not simply cognitive processing; it's actual manual labor. And where we see the benefits of AI, there are significantly less than what we see in sort of the, knowledge processing aspects of our field. And so being able to tease those two areas apart and not letting the failures of AI and maybe the sort of manual labor portion of what we do uh, negatively color its strong potential in the cognitive processing aspects of what we do, I think is key to keep in mind.
Super interesting. Anyone have anything to add there?
Yeah, I agree. I completely agree with everything that's been said and the kind of the challenge of, the risk of not learning that those critical thinking processes and will arise and where you're going to need those most are probably in the rarest and oftentimes the most severe cases, which a trainee might not ever encounter kind of throughout, during their years of residency and fellowship. So if they don't have that kind of ability to think critically and logically when they encounter it in real life, that's where we're going to that's really, really risky. In radiation oncology, because we're such a digitized field, we already have kind of AI used to help with radiation planning, and I do worry about trainees who are who are starting now and don't go through the process of kind of manually doing the radiation oncologist portion of the radiation planning, which is contouring, where we kind of outline the organs and tumor to determine, to guide the radiation beams. Um, we have AI to automate the normal tissue portion of that. Usually it works really well. But in the kind of, in patients, in some cases with abnormal anatomy, they'll fail. But if you haven't gone through the process of manually doing the contouring on your own, you're you're less likely to catch that. We're kind of addressing that by kind of requiring trainees to go through at least a set number of cases manually. Um, but it is a challenge. I think it is a real risk, and we don't, at least in my field, it hasn't been completely solved yet. How to kind of make sure that we're filling in, that trainees are still kind of gaining that like real medical expertise and kind of higher order thinking that they would need when the kind of in the rare AI failure settings.
It's actually super interesting and one, maybe nugget to give to senior surgeons who share that worry and concern is, when you have, I'll use Dr. Ali's analogy from the screw placement in the spine, right? So, screw placement in the spine is relatively straightforward when you're trying to when the spine is straight, right? But when the spine is like totally curved and, scoliotic, then it becomes, a little bit more of a skill set to understand where each vertebrae is in space. And so, maybe there's a point where we say, yes, I in those cases often like to use some type of enabling technology, right? The robot or navigation or, some other type of technology, but like, here's a moment to take kind of that mental timeout away from the enabling technology and say like, hey, let's work through this one manually, or at least this screw, or hypothetically, we obviously don't want to do anything that's not in the best interest of the patient, but let's go through this hypothetical exercise, or I want to call you all in to see this outlier case because the AI may not have seen this case. And so when you are using, a large language model for this cognitive processing of this type of case, it might lead you astray. So here's one that you really should think about or focus on, because the other rote ones, like you could argue, like maybe you don't need to, but so that they still develop that mental repertoire. And, I know it's hard for all of us because we think like, you have to be there at 3 o'clock in the morning to do it. But there may be some ways to improve the efficiency, but also still get those outlier cases. I love that idea that you guys came up with. And so, shifting one more time around, there was the couple questions about policy and bias in AI models in surgery. And so I think these are super important. Let's start with the concept of bias, because we're already sort of talking about like what's included in the models and how we're going to use it to make decisions. So when it comes to like clinical decision aids, right? So maybe going back to Dr. Tuaño's case, if you're trying to help a patient individualize based on, in this example, skin tone, preference for the donor site, excuse my trying to talk plastic surgery words, but but you're trying to optimize on these things. We can obviously design a scenario in which there could be bias there. So how do we go about ensuring, as these models are developed, that we have checks and balances for bias? Dr. Tuaño, I'll ask you to go first, and then maybe Dr. Bitterman.
Okay, well, maybe we can talk more about the technicalities of it with Dr. Bitterman and Dr. Ali, because I think they have much more experience from the actual programming side of it. But for me, in particular, I think just utilizing AI tools is helpful for maybe planning for the patient, because I think the technology is available to, for example, like show a patient what things might look like. Like we do use that a lot in plastic surgery for like virtual surgical planning, as you do in neurosurgery. And I think one of the things that you brought up is really important, which is that bias, because for some patients, for example, for a certain Fitzpatrick score or skin tone for patients, it's really difficult to predict how their scar is going to look and what the donor site is going to look like. And although that seems like maybe a secondary concern for aesthetics, actually for me as a reconstructive surgeon only, I really care about the functionality of that as well, because if they develop a very significant keloid or a very significant hypertrophic scar, it drastically changes the way that their functionality is. And another thing to think about I think of this funny conversation that I had with a resident. I was walking down the hall with them once, and they weren't going into hand surgery, but as I was walking down the hall, there were 3 or 4 people that stopped me that were on staff, and they were like, "Oh, hey, can you just look at this thing in my hand real quick?" And as we got back to my office, she was like, "Wow, I kind of didn't really realize how impactful hand surgery was." And I was like, "You use your hands all the time. We talk with them, people see them, and it actually can be very stigmatizing, you know? So a lot of times in plastic surgery, we think about a patient's face or like their lip. You can actually see an offset or a step off of a lip, for example, for a cleft lip within 1 to 2 millimeters of talking distance. And people notice that immediately with a hand. So, you know, I don't mean to be indirect with my answer of the bias, because I think the other 2 panelists can much more expertly describe how we can sort of obviate that. But just in my experience, it's really hard to try to individualize that care with an algorithm, because those are subtle things and maybe cues that you would get from a patient and speaking to them in person that you would never get even like maybe over a telephone call or a Zoom call, because I do a lot of like telehealth visits. So at least from my perspective, I think that's just like an extreme challenge, and I honestly don't know if there's a good answer. So I don't know. The other 2 panelists have a good one, but I would be happy to.
That was a super insightful answer, and I'd love to hear what the other 2 have to add.
Yeah, I think bias is super important to always think about when kind of to take the risk of bias into account when you're seeing any AI output. There are kind of 2 classes of models that have that require different thinking about the bias. There are kind of the more traditional narrow AI models that are trained on a set of clinical data where you can define this is the population that the patient this is the patient population the model was developed and evaluated on, and you can assess at least whether your patient is similar to that population. So you can at least, and that gives you a sense of, okay, the performance that was reported on that model is more likely to be reflective of what I anticipate of the anticipated performance of the patient in front of me, or not, and I shouldn't use the model for that patient. There's a newer class of foundation models, which large language models kind of sit within, that are trained on oftentimes general information on the internet for large language models, or just huge sets of kind of mildly curated clinical information for which we don't have kind of firm understanding of the population that's represented in the kind of learned representations. For those, we can't anticipate whether a model is going to perform better or worse for a specific patient group, which makes it really challenging, because we can't kind of make use of our traditional kind of assumptions about model degradation or differential performance that we were previously able to rely on. I think this is a little bit of a non-answer in that we need a lot of research in this space. We need more work in kind of understanding how information learned in these really large general data sets that these foundation models are trained on percolates into differential decision making, because we know it does. There are studies showing that it does lead to kind of differences in how a model might respond to patients, patients across different groups, but we don't know exactly kind of how those differences arise from the training data. So I think that's a gap. Right now, the best way to approach it is kind of to have evaluation, sets of, data sets that represent different populations that you can kind of benchmark your models against to get an initial sense. But it's a really challenging question with the foundation models.
That's actually really interesting. I just have a quick follow-up question for that. So my assumption was that most of the bias that came out of AI models came from limitations in input. But I think based on what you just said, that's not necessarily true, right? It's input, but also there's some areas, I guess, call it black box or that we don't understand what it's doing.
Exactly.
Yeah.
Yeah. Especially with like the new big models. We had a project where we kind of it was a few years back when the large language model started becoming really popular, where we kind of looked at, there were some data sets where you knew what text data sets the models were trained on for these for large language models. And so we tried to see whether kind of how often different words, different terms for race co-occurred with terms for different diseases, and if that associated with kind of real world different epidemiology of different diseases. And we found It did actually. So, if you have access to the data, to the kind of pre-trained data, you kind of get a sense that there would be, something real learned from just the co-occurrences, but co-occurrences don't relate to real epidemiology. And then and then with language and specific, there are weird things that occur. So we saw what we initially were like, okay, there's like really kind of strange patterns with tuberculosis, where the model was kind of finding really weird associations. When we thought about it a little bit more, because a lot of the text that these models are trained on, um, especially in the early days, was kind of preprint in the computational literature, and it was learning terabytes TB. And so there are these really kind of, these idiosyncratic associations that arise that we don't that are difficult to anticipate.
That's fascinating. Dr. Ali, anything to add to that?
Yeah, I agree with everything that's been said. And the only thing I would add is when thinking about bias with these models, it's important to think of these biases as two layers, the bias of the model itself and the bias of the user that's utilizing the model, right? And so example of a bias of the model, a few years ago, we looked at this. We looked at bias in image generating models. We said, generate a photo of the face of a surgeon, photo of the face of a plastic surgeon, general surgeon. And one model, Midjourney, across 2,000 photos, did not generate one photo of a person of color or a woman as a surgeon. So that's a bias of a model, right? The bias of user is, let's take an op report, an op note, and tell a model to say, hey, can you identify the CPT codes associated with this op note, right? And it'll generate a list of CPT codes. Then as a user, you say, hey, actually, I work for a health insurance company, and it would really help my job if you could code this in a way that, is just more, really scrutinizing it and, your fiduciary responsibility essentially to the health insurance company generates 25% fewer CPT codes, right? So there's a bias you can induce into the models as a user that's important to keep into account.
That's fascinating. I want you to chat with our coders. No, it's really interesting to think about the different types of bias, and I think that gets at the most recent question that I just saw in the chat about sort of the user bias, the data bias, and the actual model bias, which I think is adds a whole nother level of complexity. But I think that's the point, right? When we're talking about the ethical implications of AI, is to understand even the questions to be asking from a complexity standpoint. When you are doing this research, Dr. Bitterman, where are you're using publicly sourced and Epic data? Because I'm just curious for people that might be interested in trying to probe and understand, because we as surgeons probably do have a level of responsibility when it comes to understanding how our patients' data is being used and how we're using it. So let's say I wanted to look at that a little bit, like how do I do that? Obviously, I'm not going to become an expert in the research like you are, but
No, it's a good point, and it actually is challenging because it's almost not possible anymore. When we were doing that research, it was kind of, and the models were really small, and there were still some like people were actually releasing the data sets that they were using to train the models. Unfortunately, now that's not the case. And the other factor is as these models have gotten larger, the kind of ways they learn relationships between data sets has become more complicated. And it's likely, I can't say that's, I think likely learning just from the data itself won't let you anticipate to the same extent as we initially saw those biases. Um, I think it would be helpful, to gain more transparency for any model that we're using into how they were trained. Not everything is a large language model. There are different models that that you might be able to get a better sense of the biases learned from the data sets. And I think physicians are in right now kind of a place of power, and we have empowerment to say we really need to, if we're going to be expected to use models, we need to have some information about how they were, what they were, how they were trained, and how, probably more importantly, whether and how they were evaluated for these types of biases.
I actually love that as like a, a sort of a call to action for the folks on this call, especially those that, research this topic, that do clinical work, and use AI. I think, it actually gets to the last comment and question in the chat about the idea of like a white box model, just some transparency around how the model works. And I think the other piece that I would add and be curious about comments is how our patients' data goes into these models. And so I think having an understanding, who gets involved in those policy decisions and like, for example, at our system level of those decisions where, there is like a list of criteria for a new AI tool to come in and like it has to have transparency or it has to have like who's involved in those types of decisions. And then go ahead, Dr. Tuaño, because I know you were about to say something too.
Yeah, thanks so much. I guess sort of continuing on this topic of, utilizing patient data and where it's going and bias. I had two recent experiences that made me think about these, and I'd love to hear what the other panelists have to think about it. But one instance that I was thinking about was I was sitting at Flower waiting for my coffee, and on the wall they had the famous Sir William Osler quote, which is, "The good physician treats the disease, but the great physician treats the patient who has the disease." And it made me think of this patient that I recently got involved with that had been seen by a multidisciplinary care group for months and months, like since October. And I mean, much smarter people than me had seen this patient. He had been presented at so many different conferences, and nobody could figure out what was wrong with the patient, at least seemingly. And the patient came to my clinic. It was sort of like an SOS call. It wasn't a day that I had my actual standard clinic, and they were like, "Oh, something's really wrong with the patient. Can you see them quickly?" And after some time and reviewing the chart for hours, I personally also couldn't figure out what was wrong with the patient. So I said, "Okay, I'll do a biopsy." Anyway, fast forward, and after developing some type of a rapport with the patient, which in my case was only about a week and a half, I then contacted the people that had known this patient for 6, 7 months. And I said, "I'm really sorry to say this because I know I'm like the new person in the group, but I have combed through this patient's chart for hours and hours and thought about this for days and days. And I think this may be factitious." And in my own clinic, I use DAX all the time. I use an AI scribe. And for some reason, whenever I was in the room with this patient, I thought I shouldn't use this. And it may be making them uncomfortable or introduce a type of bias. And I remember when our group had written a paper on machine learning and pain sketches on amputees and phantom limb pain, there was some concern that like maybe some patients weren't writing their certain pain postoperatively because they were almost quote unquote embarrassed to write that they still had pain or that they were this debilitated. And I just wonder, what stewardship we should sort of think about when we're putting patient data into there, because before we ever entered into the patient's chart factitious, we each had individual conversations outside the room. We made sure that we didn't tell anybody at the nursing station. We made sure we didn't tell the residents. And we made sure that the patient stayed in the hospital and felt very safe for at least almost 2 weeks before introducing the idea of psychiatry, even though the patient had an outside psychiatrist. And I think that is very alarming for patients. And something that was interesting for me was our social worker actually pulled up the patient's gateway records and saw that the patient was checking their gateway every 30 seconds. So because it's released immediately to the patient, what does that do to their, psychosocial state? And what is our responsibility then as physicians that have these metrics that we have to document everything within 24 hours? So.
Yeah, I think that's super interesting and it's a challenge, right? Like I think adding to the list like the stewardship around, patient data, how that will ultimately be used and how, a scale that scores certain things. I'm thinking of, other sensitive topics like things like obesity, et cetera, that like, then get kind of plugged in the chart in a way that like a human wouldn't necessarily write it or deal with it in real time. And I think we're kind of facing these. I personally also have a fair amount of patients now that will take their MRI report, put it into ChatGPT, and then come with, the output. And, it can make the sort of doctor-patient relationship portion of that really quite the challenge. And so I think it's really important that we think about how we as physicians are also the humanistic side of making sure that we incorporate the human interaction into AI. In medicine and in surgery. So I love that you brought that point up. We have sadly only 3 minutes because I have so many more questions. And so I think, getting at, maybe we'll just do kind of closing thoughts from each person, thinking about, some of these concepts of like what the responsibilities are, what the policies are and who should kind of be involved in these conversations. And then we'll wrap things up. So maybe we'll go in the same order. We'll do Dr. Bitterman, Dr. Ali, and then Dr. Tuaño.
Sure. Yeah, I think one area that I am worried about and feel very passionate about is that physicians and patients are being too much left out of the conversation of where AI advances in healthcare are going. The kind of discussion is increasingly being led by developers. And I think clinicians and patients should not feel intimidated by the kind of the fancy tech words they use. We have the knowledge of what is going to be impactful. And that's actually the highest value kind of expertise to bring to developing and evaluating these models. So my kind of final statement would be like, please get involved in this research. Please kind of be open, kind of if you're interested, kind of start collaborating with computer scientists. A lot of them are really excited about using these models to advance healthcare. They don't know the right answers to go after, and it's just a huge opportunity, untapped potential to direct these advances in the right direction to make physicians' life easier and, more importantly, improve patient outcomes.
Amazing. Dr. Ali.
Yeah, and just to sort of echo that, what Dr. Bitterman said, I mean, I think we're seeing now in survey responses that, majority of physicians are using these AI tools. We see patients coming into clinic using these AI tools all the time. I think that ultimately should be encouraged because that's really going to lead to more engagement by patients and more understanding of their own healthcare. And as clinicians, I think we should just meet the patients where they're at, as Dr. Tuaño so beautifully put it, really individualize that care for the trainee, for the patient you're meeting, and acknowledge the fact that we're all starting to utilize these tools more and more and incorporate that acknowledgement into our everyday practices.
Thank you so much. And Dr. Tuaño.
Yeah, I mean, obviously I agree with everything that everyone said. And I guess the most succinct way that I can put it is our ethical obligations in general with utilizing AI are that things change and our ethical obligations change, I think, especially as things are sort of more developed. And it's a shared decision ultimately in the end with yourself and the patient. And it's just really important that AI is used as a supplementary tool and not the only tool. And it's used as a reasoning tool, but it's not a replacement for clinical judgment. So as a daily user of AI myself, on the top of my group's notion, it says, treat every patient like family. And I'll leave it at that, treat every patient like family.
Thank you so much, all of you, the panelists, for being here and for sharing these insights with us today. I feel like I have some like real take homes that I'm excited about and eager to answer the calls that you guys have laid out and also more knowledgeable about how AI is used in surgery. So I can't thank you enough for being here. For those who are interested in taking us up on that, please follow or continue to follow the HMS Center for Bioethics. Reach out about the Harvard Surgical Ethics Working Group. Look us up at neurotechjustice.org for the Neurotech Justice Accelerator. We do a lot of this research. We also have an upcoming seminar on June 12th called Digital Neurotech in Your Pocket. So we'll be talking about the specifics of neurotech in this field. And so please continue to be part of this journey with us about AI in surgery. And also thank you to the Center for Bioethics and our group and Nichelle for putting this all together. So thank you so much. Be well, everyone, and look forward to continuing this work.